From MicrobeTV, this is TWiP, This Week in Parasitism, episode 286, recorded on August 12th, 2026. I'm Vincent Racaniello, and you're listening to the podcast all about parasites. Joining me today from New York, Daniel Griffin.
Hello, everyone.
Daniel is like fooling everyone because it's not STI. It's not Friday. We're recording on a Wednesday today. It's unusual, but he's still wearing an STI tie.
I have my trick bow tie. It's just because I was saying earlier, it's This Week in Parasitism. It's all about parasites. So I want to wear a parasite-appropriate bow tie.
That brings up a question, but let's introduce our other host so I don't go a half hour without introducing her. From Glasgow, Scotland, Christina Nowla.
Hello, good evening, everybody.
So of all the parasites, how many are sexually transmitted, Daniel?
That's like a Dixon question. He would know that, and he would I sort of have to go through them and sort of think about them like one at a time.
The one you're on your tie, that's one of them,
so,
right?
Yeah, so trick would be yes. Amoebiasis, right? We've seen some sexual exposures where that gets across. Most of your helminths, they're not really going to get transmitted sexually. Makes me think about like our protozoan parasites. Maybe Christina, you want to jump in and help me out? Any thoughts on how many?
I think the ones that you mentioned is the ones that I was thinking about. I guess it would be not routinely sexually transmitted other than trichomonas, wouldn't it?
Yeah, it is interesting. So I have in one of the lectures I do where I talk about, how parasites take advantage of our behaviors. And I should grab that slide. It's a slide I do a talk for floating doctors down in Panama. And we may even have in our book where I kind of go like, what are the different ways things are contracted? What are the exposures? But yeah, no, most if you think about it, most of our parasites are not really those sexually transmitted infections.
Mm-hmm. So I've said here, I've seen intestinal protozoa. You've already mentioned it, amoebas, didn't you? So Giardia, I suppose, potentially.
Potentially.
Yeah.
Yeah, we do see a higher incidence in certain populations with that speculated as how it's transmitted.
And then obviously
scabies,
the ectoparasites like pubic lice and scabies.
Ooh, pubic lice. I wasn't even thinking of pubic lice.
But scabies, we had a case of scabies that was sexually transmitted.
Yeah.
I mean, just by contact, right?
Yeah, but that sort of intimate contact, which can happen with sex, you could end up with a transmission event. Yep.
Okay, I was just curious about that.
Let me see. So we actually, in our clinical appendix 593, we have different types of exposures. So we have oral, and that's like a lot, typically contaminated food or water. We have all the vector ones. Then we have contact, right? And it can be mucous membranes, intact skin. So there you've got, lice, right? You brought that up. The myiasis, maybe. Scabies, trichomonas. Yeah.
Okay.
All right.
Here we go, folks. Another lesson.
We learned something today.
Yeah, we learn every day. Every podcast is an opportunity to learn. And if you like learning with us, if you like science and like to learn it along with us, we'd love your support to help us produce these podcasts. You can go to microbe.tv/contribute. So today is time for a clinical case reveal. And Daniel, tell us what we're working on these weeks.
All right. So this was a recent ID consult, and so this is an MD PhD, a clinician researcher, physician researcher, mother, doing research, married with a 2-year-old child. Initially, the story I got was the child was older. I was like, it would make more sense if it was like a 2-year-old. And yes, it was a 2-year-old. So this young lady develops anal irritation. The husband is fine. The child is fine. A parasitic etiology is considered, and this individual is referred to an academic ID practice, where it turns out that she ends up getting some treatment, gets a little bit better, symptoms return, treated again, got better, symptoms return. So the ID physician says, I really need to confirm this diagnosis. So they find some difficult to procure testing equipment, and the suspicion is confirmed. So they treat once and then again in 2 weeks. Not any better. This is actually when I get sort of called in. What's going on? Why are they still having issues? We got a few questions. HIV negative, no prior medical issues, no travel. All right.
Christina.
Shall I read the first one? Walter writes, Dear TWiP hosts, greetings from a rainy Melbourne. You did that on purpose, I would say. The city wrong again.
Melbourne.
Right. Melbourne. Okay, right. The case with anal irritation sounds like pinworm. You can treat it with albendazole once, then again in 2 weeks. Just as you said, although to limit reinfection, you might want to treat the entire family as well and wash linen, clothes, etc. The moral of the story is wash your hands before you eat. Truly wise words to live by. Thanks for the episode and have a nice day.
Wash your hands before you eat, yes. Or before you touch your face. Daniel.
Alan writes, Dear TWiP team, I am a recently joining listener and first-time responder excited to share my thoughts on this case. I am an undergraduate at the University of Washington in Seattle, where I've had experience with infectious disease research and was recommended to listen to this podcast by Dr. Drew Bell when I took his parasitology course last spring, and I'm thoroughly pleased with his recommendation. In fact, if my diagnosis is correct, then that is only because Dr. Bell had covered this parasite in his course along with the memorable diagnostic exam. For the case of the mother in her mid-30s who recently redeveloped anal irritation with parasitic etiology considered, I believe the responsible parasite is Enterobius vermicularis on account of the symptoms, environmental factors, and pattern of recurrence. The development of perianal itching immediately made me think of E. vermicularis, as that is the characteristic symptom of the parasite. The itching is caused by migration of female adult worms from the small intestine to the anal area at night to redeposit their eggs. Itching additionally facilitates autoinfection and transmission through contamination of fingers and any nearby surfaces, bedsheets, clothing, etc. And the ensuing ingestion of eggs, as well as the occasional migration of larvae back into the rectum and to the small intestine. I am not familiar with other parasites that would cause this symptom, but E. vermicularis is certainly the first thought for me. The second clue to this diagnosis is the environmental conditions. School-aged children are particularly at risk of E. vermicularis infection, which makes environments like childcare hotspots for infection, easily translating to household transmission. The third clue is the pattern of recurrence. Initially, this gave me pause, as the timeline does seem a bit odd. However, it is known that young worms and eggs can be resistant to the standard treatment of antihelminthics, necessitating a second dose after 2 weeks. This regimen has a high cure rate, but recurrence is common, possibly from environmental contamination, as eggs can survive on bedding and household services for weeks. In highly recurrent cases, a pulse scheme may be used, where treatment every 2 weeks can continue for up to 16 weeks, which is what I would recommend in this case. Given that the physician reported diagnosing this patient with a parasite, I would assume that they used the iconic tape test, transferring clear, sticky tape from the perianal region to a glass slide, allowing for microscopic examination of the visually distinct ova. Diagnosis with E. vermicularis, especially more than once, would make me think that the physician ordered the standard treatment or even pulse schedule, but it's possible that they didn't suggest diagnostics for the household or the childcare facility didn't notice this in other children, both which are possible sources of transmission. In this case, I'd consider it likely that the child and father are also infected but are asymptomatic, which could easily lead to chronic infections such as this. Given that the symptoms did not resolve after initial treatment, I would recommend the pulse scheme for the mother, thorough decontamination of the household environment, and testing the father and child for E. vermicularis, along with follow-up evaluations to ensure the infection is clear at this time. Issuing a notice to a child care facility to watch for symptoms among the other children may also be advised. It's also possible that the perianal itching facilitated a bacterial superinfection, but I would assume the reinfection scenario is more likely and would pursue this finding until the parasite can be ruled out. Please excuse the long-winded response, and I look forward to hearing the team's discussion.
John writes, "Dear esteemed hosts, I've been tied up with caretaking, but still love watching, and I've had to keep my guesses to myself with less time available, but I'm glad to get one in this round. Enterobius vermicularis, commonly known as pinworm, isn't known for causing disease and can be treated with medications and hygiene awareness. These nematodes can show up in stool and be motile, small white round worms with life cycle measuring in weeks, lining up with the patient's timeline. The clarification that the dependent was 2 years old and not a teenager makes a difference and is likely picking up pinworm in childcare and transmitting it to mom. So long as this route of transmission isn't shored up, it can continue to return despite treatments. A Scotch tape test could confirm diagnosis since the eggs are not laid inside the GI tract, but outside on the perianal area, which is why itching is often associated. An oviparasite test coming back positive may have been used. It's good to rule out co-infections, too, in the case of pinworm, so I wonder if anything else was tested. Treatment can be expensive, but Parental is comparably cheap OTC medicine that can save hundreds of dollars on its alternatives, where if taken a second dose 2 weeks later approaches 100% efficacy due to the multi-week life cycle of pinworm. Child should be tested and treated too, and child care alerted to the situation, as there is probably another families experiencing similar woes. It was nice to see Vincent in Minneapolis, and I actually got to tell him my guess at dinner, so I hope it's correct. And he signed my 8th edition book, Cheers. I'm not an author of the 8th edition, but there's a picture of me inside, so I signed the picture.
You are welcome to sign. Well, it's a production of This Week in... with Parasites Without Borders, and you're on the board, you're a director, okay. So yeah, you can sign away.
Thank you very much. Christina.
Kevin writes, "Greetings, Vincent, Daniel, and Christina. The riddle about
airborne.
It says airborne
Christina.
Because I was going to be flying on a Friday, remember, but we're recording on a Wednesday, so I'm actually still sitting in my little office in Glasgow. I will be airborne. The riddle about the MD PhD wife mother with chronic recurrent perianal inflammation itching, partially and temporarily relieved by an undisclosed treatment, made me immediately think of pinworms, especially when Vincent asked if the physician's hard-to-find piece of diagnostic equipment was Scotch tape, and Christina asked if the family's washing machine was broken. I'd forgotten about that. Learning that the couple's child was 2 years old and in daycare reinforced my suspicion of pinworms, Enterobius vermicularis. The only thing that made me have doubt was that neither the child nor the husband, father, had mumps symptoms. So I had to consult my old friend, my 14th edition of Harrison's Principles of Internal Medicine, the chief editor and author of some sections, the illustrious and now outrageously persecuted Dr. Tony Fauci. There I learned that while pinworms are common among family members owing to ease of person-to-person spread, most cases of enterobiasis are asymptomatic. Particularly fascinating is the life cycle of the pinworm, whose sole natural host is humans. Adult pinworms are about 1 centimetre long and dwell in bowel lumen. They are individually either male or female and sexually reproduce. At night, pregnant females migrate out of the perianal region and release up to approximately 10,000 immature eggs each. Within a few hours, the eggs become infective and are transmitted by hand-to-mouth passage. One can easily imagine the microscopic eggs being lodged beneath the fingernails as one scratches the itching in the perianal area, even in one's sleep. the itching is worse at night due to the nocturnal migration of the pregnant females, resulting in self-infection when fingers are brought into contact with one's mouth. The eggs hatch and larvae emerge and mature entirely within the intestine. That life cycle takes about 1 month, and adult pinworms live about twice that long. Since pinworm eggs aren't typically released into the bowel, looking for eggs in the stool isn't a means of diagnosis. Rather, the good old cellulose tape method is employed, with the lengths of the tape pressed into the perianal region in the morning. The textbooks give the characteristic features of pinworm eggs as being oval-shaped, flattened on one side, and measuring 55 by 25 microns, making them visible under low-power microscopy once the cellulose tape matter is transferred to a slide. Based on this information, it's apparent that the doctor, mother, wife is not an asymptomatic carrier of the parasite, whereas the husband, father, and 2-year-old child undoubtedly are. The reason the malady returned a month after treatment was failure to treat the husband and concomitantly child. Accordingly, all 3 need to be treated with the appropriate agent in order to eliminate potential reinfection from asymptomatic family members. Chapter 222, that's one big book, of items recommends a dose of mebendazole or Pyrantel palmate, repeated in 10 to 14 days. Perhaps a newer, better therapeutic agent is now available, as the 14th edition of Harrison's Internal Medicine was published nearly 30 years ago. Of course, it follows that all bedding and clothing must be well laundered as well, without family members re-wearing, without laundering, clothing previously worn within the previous several weeks, perhaps up to 2 months. Obviously, there are many reasons such an unhygienic practice should be avoided, including the social distancing that others would practice when one came within a few feet of them while wearing dirty clothes. I did not consider differential diagnosis because all the elements of this case pointed to family enterobiasis, applying Occam's razor. Also, I did not want to employ AI-assisted search engines, though some possible zebra hoofbeat alternative diagnoses come to mind, all of which, however, are precluded by a positive cellulose tape test. Please pardon me for being unable to close without expressing my literal horror over the Joe McCarthy-esque, Stalin-esque travesty perpetrated by Rand Paul, Josh Hawley, and the other MAGA-Maha Republican cultist sycophants of dear leader against the esteemed Dr. Fauci in a Senate subcommittee kangaroo proceeding 3 weeks ago. Every time I think things could not possibly get worse, they do, in a multitude of ways. I practiced criminal defense and constitutional law for 30 years, and watching that scapegoating and denial of fundamental fairness traumatized me. But it was encouraging to see Dr. Angie Rasmussen's spirited discourse on the ever-accelerating war on science and truth on Rasmussen Retorts, number 9, in which she also predicted with precision what was going to transpire a month later in that anti-Fauci star chamber. But I'm also very anxious about things based on the ease with which people across the political spectrum jumped on the Crucify Fauci bandwagon, having no knowledge whatsoever about virology and no interest in reading the PNAS article debunking the Russian propaganda-based nonsense, implicating Dr. Fauci in a diabolical conspiracy to unleash a lethal virus upon the world. If you're interested, I'll trade you my Deport Fascist t-shirts for some MicrobeTV bling. I washed it, I promise. Thanks for all you do.
That's perfect for this episode. Daniel.
Pravina writes, Dear TWiP team, thank you for your entertaining and enlightening podcast. I am a pediatric infectious disease physician from Kerala, the southernmost state of India. This is the first time I'm writing to you. Your podcast has become one of my favorite ways to learn and brush up on parasitology. Producing such high-quality scientific content consistently requires an enormous amount of time and energy, and I want you to know that it is genuinely appreciated. Regarding your case of the young MD PhD mother with anal irritation, which seems to be resistant to treatment, it looks like one of those scenarios that we do come across in our practice. The history is typical of pinworms. The perianal itching at night, having young kids in the family, not getting better with 1 or even 2 courses of albendazole, all points toward the possibility of pinworm. Worm infestations are very common in our part of the world, and I understand it must not be that rare in the U.S. as well. I have done my pediatric residency in India as well as the U.S., and I have not seen many pinworm infestations while I was there, but in this case, I cannot think of anything else. Pinworm is seen in all socioeconomic classes. The adult female comes out into the perianal area at night to lay eggs. It causes intense itching due to the localized inflammatory reaction of migrating worms. When girls come with vaginal itching, pinworm is one possibility that we think of since it could migrate to the vaginal area as well. Regarding diagnosis, stool for ova and parasites can be negative because eggs are not usually shed in stools. Is the transparent Scotch tape test, which will help in the diagnosis. Single dose of either albendazole or mebendazole or parental palmoate is initially given. As none of the drugs act against eggs or developing larvae, a second treatment 2 weeks after the first dose is recommended. But sometimes that is also not enough. Autoinfection, retroinfection, and transmission via fomites are all possible in cases of pinworm. Eggs can also be dispersed into the air and contaminate the environment. Hence, reinfection from close contacts is possible. Therefore, other members in the family, especially children, have to be treated simultaneously with the same 2-dose regimen. Since pinworm eggs can survive outside the host for a long time, all towels and bed linen in the household should be laundered on the day treatment is taken. Other preventative measures, like bathing in the morning to remove eggs, frequent hand hygiene, clipping of fingernails, are all helpful in decreasing the risk of autoinfection and continued transmission as per the Red Book. Drug resistance to benzimidazole has not been documented in pinworms. Single dose of ivermectin is another drug which can be effective. Nonetheless, treating the family as a group and other hygienic measures would be important here. Please keep up the excellent work. I look forward to your future episodes. With warm regards, Pravina.
Simon writes, my guess for the MD PhD with anal irritation that keeps recurring 2 weeks after treatment is pinworm, Enterobius vermicularis infection. The poor woman is being reinfected because her 2-year-old child is not being treated concurrently, and the husband also. Perhaps she changes the diapers and not the husband.
Was that changing of the diapers or the changing of the husband?
Yeah, right, both. Also, no mention is made of washing all bed linen and bedclothes in hot water. Could the hard-to-find testing equipment be a pinworm paddle? I'm a little uneasy with this guess for 2 reasons. First, 2 weeks seems a little short for the time span from reingestion of eggs to anal irritation. Secondly, pinworm seems a little obvious. If this is a trap, then you got me. I walked right into it. Kind regards, best wishes from Simon from Brisbane, who has received the book and is overjoyed with it. There you go. There's Albert, your friend.
I know. Albert writes, Dear TWiP professors, greetings from Malaysia. Thank you so much for the book from episode 284. I'm eagerly awaiting its arrival in the mail. Regarding your case, our MD PhD colleague most likely has Enterobius vermicularis infection. Her recurrent symptoms, despite repeated treatment, are almost certainly driven by reinfection receding from her asymptomatic child. To break the cycle, the entire household requires simultaneous treatment with albendazole on day 1 and day 14, alongside environmental measures like washing bed sheets, pajamas and toys in hot water. Close contacts at childcare, including children and teachers, should be evaluated and treated. The hard-to-find testing equipment was likely a commercial pinworm paddle, though a Scotch tape test should do the trick. I attempted the tape test a few months back on a patient, but it was challenging. Many public hospitals in Malaysia lack air conditioning, and the perianal region is almost always damp due to the hot and humid climate. The tape struggled to adhere, and I hesitated to wipe the perianal area dry for fear of dislodging the precious eggs. Looking forward to the reveal and discussion. Warm regards from Albert in Malaysia.
So, Albert, your book shipped today, by the way. I have to say, we were originally going to send it by FedEx. Do you know what they wanted? To ship a book to Malaysia? $320.
Blimey.
And then we brought it to the U.S. Postal Service. Bless them for $50. It's on its way.
Wow.
Daniel, you're next.
Simon writes, this sounds like pinworm, species Anaerobius vermicularis, given the symptoms, timeline, and Scotch tape.
You can take the next one, Daniel.
Susan writes, it's pinworms. Anal irritation is too mild a term for it. The gravid female Anaerobius vermicularis emerges from the colon to the sensitive anal area, where she deposits her ovaries on the perianal folds and uses her long, pointed tail to irritate the area. The host will be hard-pressed to resist the urge to reach back there and scratch furiously, getting pinworm ova beneath her fingernails. The worm is especially active on the perianal area at night when the host may be somnolent and lack inhibition about scratching herself. The host can easily re-inoculate herself or inoculate others via hand-to-mouth route. Anaerobius is most common in young children, but adults who spend time with children may be vulnerable. Larvae hatch in the small intestine, and the adults move on down to the colon. The life cycle from ingestion of ova to the next generation of gravid adults takes about a month. Diagnosis may be via the Scotch test. Household transparent sticky tape is applied to the anal area and placed on a microscope slide for examination for ova, or an adult specimen may be observed on the anal area or in the poo. Treatment is by washing bed linens and clothing in hot water, frequent furious hand washing using a brush under the nails. An antihelminthic should be given to all human members of the household. That's in bold. Repeated again in 2 weeks. Anaerobius vermicularis is distributed worldwide and is an exclusively human parasite. It is not particularly harmful to most, but you won't soon forget that itching.
I really like that Susan found a pinworm emoji to put in her message.
It's kind of cool that there's pinworm emojis.
Yeah. It's probably a generic worm, but we take it.
Yep.
Justin writes, hello, dear hosts. In the case of the MD-PhD patient suffering from persistent anal irritation, my guess would be a pinworm infection. I'm wondering if the recurrent nature of the infection is because the entire household was not treated, as well as potentially only giving one dose treatment does not kill the eggs. As for her recent persistent infection despite treatment, I wonder if antibiotic resistance might be considered, though I am unsure if that is a possibility here. As a point of interest, each summer for the last few years, I have been involved in genotyping cases of cyclosporiasis, and as you can imagine, this year there has been some additional interest in that particular parasitic infection. Perhaps Cyclospora cayetanensis will be discussed soon on a future episode of TWiP, and indeed, it has been. It was just released. Maybe you missed that one, Justin.
Justin may have written before, right? That is probably that's been a popular episode.
Very popular, yes. Very popular episode. Okay, now, Christina, it is your turn.
Shlomi writes, greetings, esteemed professors and fellow Helminth enthusiasts. My name is Shlomi, a third-year resident and soon-to-be ID fellow. I'm a long-time listener, first-time responder. The case presented of healthy adult with a 2-year-old child that presents with pruritus anis that responds to treatment but then recurs immediately brought to mind an Anaerobius vermicularis infection, or pinworms. The very hard-to-find diagnostic equipment usually involves Scotch tape applied to the anus to visualize the worms. The fact that she initially improved with treatment and then the symptoms returned implies either a partially treated infection or a refractory one. You should receive a second dose 2 weeks later to make sure to eradicate all the eggs in the intestines. Furthermore, there should be a number of hygienic measures that need to be performed, such as high-temperature washing of linen and clothes, in addition to good nail and nail bed hygiene, because the eggs can enter that space and cause auto-inoculation. It is also recommended to treat all the family members, especially in repeated infections, as most infections are asymptomatic and family members can become household reservoirs unwittingly. Another possible etiology for refractory enterobiasis is vaginal infection. Anaerobius vermicularis can on occasion infect the vagina, fallopian tubes, and sometimes even the vagina. A pelvic exam should be performed preferably by an OB-GYN to assess for infection. I would also assess for constipation in our patient, as that can impact the effectiveness of treatment. Treatment usually consists of a 2-dose albendazole, mebendazole, or pyrantel palmate, given at the 2-week interval. Although in refractory cases, one can consider a 3-dose regimen or even up to 8 doses of treatment. Mebendazole showed the best result in refractory cases. Thank you. I really enjoy your podcast. It's fun, entertaining, and very informative.
You have to tell us where you're going to be doing that ID fellowship. All right. Hans writes, "Hi, Vincent, Daniel, and Christina. This is most probably a pinworm infestation. It's a helminth called Enterobius vermicularis that only infects humans. At night, female gravid worms migrate out of the colon and emerge through the anus to deposit about 16,000 eggs in the perianal area. This causes intense pruritus ani, which often disrupts sleep and leads to scratching and further spreading of the infection via fecal-oral route. Diagnosis is with the Graham test, aka Scotch tape method, which should be done first thing in the morning by pressing firmly the transparent tape onto the anus and then inspecting it under a microscope. Bendazole or L-bendazole are very effective at killing adult worms, but not the eggs. Because of this, a second dose must be taken 2 weeks after the first one to ensure that all pinworms are eliminated. Thank you very much for all your excellent teaching. With cordial regards, Hans."
Francesco writes, "Dear TWiP friends, greetings from excessively hot Innsbruck. For the case of the doctor with anal itching and the 2-year-old daughter, my guess is Enterobius vermicularis, the human pinworm. First infection occurs after ingestion of eggs through either contaminated food or when your infected toddler decides to check your teeth for cavities after having given his itchy behind a nice scratch." Boy, is that graphic. These mature to adult worms in the intestine. The adults crawl out of the anus at night to lay eggs, causing the typical anal pruritus. Scratching the area gets the eggs under the nails so that they may be further distributed to other hosts or reinfect the original host. Kill the parasites with mebendazole, repeated in 2 weeks. Treat whole family and daily wash intimate garments and bedding at 60 degrees. Worm regards, Francesco, returning champion. You know, kids are wont to do those kinds of things. They like to play with adults' mouths, you know?
Yeah, I've noticed that. The kids like to put their fingers in, yeah.
Yeah, so adults, just watch out. Christina.
Carl writes, "Dear TWiP team, greetings from Germany. I would like to submit my answer to the case of the pruritic PhD from the last episode."
That's a good one.
I like that, pruritic PhD.
The clinical picture of predominantly nocturnal perianal pruritus, particularly in a household with a toddler attending childcare, is highly suggestive of pinworm infection or enterobiasis. The infection is caused by ingestion of embryonated eggs of Enterobius vermicularis. After ingestion, the larvae hatch in the small intestine, while the adult worms reside mainly in the cecum and adjacent colon. At night, gravid females migrate onto the perianal skin and deposit their eggs, causing the characteristic pruritus. Because the eggs adhere readily to the skin and surrounding surfaces, scratching can contaminate the fingers and fingernails, resulting in autoinfection or transmission to other household members. The history and clinical presentation may be strongly suggestive, but confirmation is usually obtained with an early morning cellophane tape test. This should ideally be performed on 3 consecutive mornings before washing, dressing, or using the toilet, with the collected eggs subsequently identified by microscopy. Less typical manifestations include vulvovaginitis in women and, more rarely, appendiceal colic or an appendicitis-like presentation, especially in young patients with a high worm burden. E. vermicularis is sometimes found in the appendix, although its role in causing true acute appendicitis remains uncertain. Management combines antiemetic medication with measures intended to interrupt household transmission. Treatment generally consists of mebendazole, albendazole, or parenteral palmoate, followed by a second dose 2 weeks later. Household members and close caregivers should generally be treated simultaneously, particularly in recurrent cases. A recent open-label randomized trial in children found that albendazole, mebendazole, and parenteral palmoate had similar efficacy in inducing remission. Mebendazole was associated with fewer recurrences in that particular study, although this should not be interpreted as definitive evidence of its overall superiority. The necessary hygiene measures can admittedly be rather demanding, especially in larger households. They include thorough hand washing, keeping fingernails short, avoiding nail biting and scratching, showering in the morning, changing underwear and nightwear daily, and frequently hot washing towels, nightwear and bedding at around 60 degrees. Bedding and clothing should be handled without shaking them, and towels and bath water shared. These measures should be continued by the household for 2 weeks after the final treatment dose. Recurrence is common and usually reflects renewed exposure, autoinfection, untreated or asymptomatic contacts, or incomplete coordination or treatment rather than confined drug resistance. To my knowledge, clinically relevant benzimidazole resistance has not been established in human E. vermicularis, although the available evidence is limited and does not allow resistance to be excluded completely. I would therefore be very interested to hear whether you have encountered any convincing evidence of it. Because you stated that diagnosis in this case had been definitely confirmed, enterobiasis would remain my leading explanation. I would first establish whether active infection is still present and review the timing and dosing of treatment, simultaneous treatment of household contacts, and continuing exposure through childcare. Repeated coordinated anthelmintic treatment together with practical and non-judgmental hygiene counselling would be appropriate. If the TWiP test had become negative despite persistent itching, I would also consider residual irritant dermatitis from scratching or an alternative cause of pruritus ani. Finally, the patient should be reassured that enterobiasis is highly contagious but usually benign and readily treatable. The idea of a worm infestation, particularly in an adult, can produce considerable embarrassment, stigma, and psychological distress, none of which is warranted. Other differentials I considered in a younger woman with anal pruritus included irritant or contact dermatitis, hemorrhoids, anal fissure, candidiasis, scabies, and iron-deficient anemia. But then again, this show is not called TWiP for nothing. All the best and keep it up. Keep up the great work, from Carl.
All right. Rainey writes, "Hi, docs. My guess is simple irritation from something consumed in the diet, spicy foods like chilies or black peppers. Keep up the good work. I've not missed a single TWiP clinical update since COVID." So I do another one. I'll do another one. That was kind of short.
Go ahead.
Ida writes, "Dear Twiplets, it's me again, Ida from Vienna, who shared her very first parasite-ridden steps on this podcast only a few weeks ago. I was so delighted to hear my mail being read on the Last Cases episode, especially because Christina's cat enthusiastic went ahead and typed their very own response to it. As you can see, I have returned for a second time, giving my best guess at the new case and excited to learn the solution. Since you described only anal irritation as a clinical symptom of this patient, my working diagnosis pretty much immediately narrowed down to what I believe is called pinworm in English. It's a result of an infection with Anaerobius formicularis, a small kind of worm that usually affects babies and children, though obviously adults can be infected just as well. This would fit the patient history quite nicely, since it basically occurs all over the world, isn't restricted to tropical and subtropical climates, like, for instance, Strongyloides stercoralis, which also tends to cause anal irritation, as far as I know. My suspicion was further confirmed when the diagnostic instrument of a Scotch tape was mentioned, as I was taught that the easiest way to detect pinworm infection is by placing a strip of it at the patient's perianal region and licking at said strip under a microscope. If it is indeed a pinworm that's causing the itching, one should then be able to view the eggs on the tape strip deposited there, usually overnight, by the female pinworm. A quick glance over some of my parasitology textbooks enlightened me to the fact that immature pinworms are resistant to the commonly used anti-helminths, which is why 2 doses of treatment are necessary and sometimes even more cycles. This would explain the persistence of symptoms despite being treated with the correct medication in the presented case. It's also important to screen the other household members for infection, as sometimes they can be asymptomatic but still excrete pinworm eggs, effectively auto-infecting again and again or spreading the worms to the treated family member again via fecal-oral transmission. I feel a little bit more confident with this week's guest, as it's a parasite that was actually covered a bit in my own classes about microbiology. But I'm still learning loads of other new things each time I prepare my emails to you, and much more so when hearing all the other guesses in your episodes. So I don't just want to thank you for hosting this awesome podcast and continuing to edutain me during my summer break, but also to all the fellow guessers, or some case knowers would be more accurate. I am frequently blown away by the vast depth this community offers, and I greatly appreciate being able to profit from your vast experience. Everybody have a lovely few weeks until the next TWiP episode. I can't wait to join you again and learn a thing or two about everything wriggly and squirmy. Kindest wishes to all of you, speaking and listening, Ida.
Helen writes, Dear TWiP hosts, I discovered TWiP a few years ago alongside TWiV, Twin TWiVo, Office Hours, and TWiV Clinical Updates, and learned a lot from you. Thank you for all you do for science communication. This is my first ever guess, and it is solely made based on what I learned over the years from your wonderful podcasts. No book, no internet search, no cheating of any kind. I don't know what cheating would be, actually, right? I mean, I think learning is learning, right? I would like to be considered for a book if I am guessing right, so here we go. I suspect the MD PhD mom is infected with pinworms. Pinworm females, or hermaphrodites, I don't remember, live in the GI tract of infected patients and stick out of the anus at night to lay their eggs in the perianal area. These fertile eggs are causing the anal itching, and they can infect other hosts through the anal oral route. Pinworms typically infect children. Sandboxes, anyone? The mother has been infected by her son, probably because she is likely heavily involved in diaper changes and or laundry duties of soiled clothes. She has been treated many times by various physicians, but because the son has not been treated, she has been reinfected time and again. The co-parent may be infected as well, but asymptomatic. The proper diagnosis is made with this very expensive piece of diagnostic equipment called tape. The piece of tape is used to collect these fertile eggs in the perianal area in the morning so they can be analyzed under a microscope or maybe a PCR by a pathologist. To solve this infestation, the whole family should be treated with the correct anti-helminthic. Sorry, no drug comes to mind because I'm doing everything based on my recall of your previous cases. The parents should thoroughly sanitize all the soiled clothes, bedding, blankets, rugs, toys, etc. that may have been soiled. Kiddos are not shy about scratching their itches and spreading the joy of pinworms with their caretakers. On second thought, maybe they should burn down the house and its contents for good measure. Just kidding. Best regards, Helen. Oh, right. Boy. This is very... So, I'm thinking, well, let's find out what this really is. Then I have a comment.
Well, we get 2 more guesses. Did you want to jump in there? Did you have a guess there, Vincent?
Scotch tape, man. It's a pinworm for sure.
But why didn't she get better, right? Let's see.
Well, because she keeps getting reinfected, right? Because it's probably in her household. She probably got it from her kid. You said 2 years old on purpose because the kid's probably going to daycare where he or she picked it up, and the kid's still infected. So the academic, it's funny, you said that she went to an academic ID providers. Are you an academic ID provider, Daniel?
That's interesting. Sometimes.
Well, anyway, I got the impression that they weren't really on top of things, or else they would know that the family has to be treated, right? And so that's why she got reinfected.
They might know that. They might know that.
So then why didn't they recommend treating the whole family?
We're not sure. Maybe they did. We'll have to find
maybe
out.
they did.
Yeah.
Okay. That's my guess anyway.
Okay.
Pinworm.
Christina, what are you thinking?
Well, I think, it has to be pinworm, really. And look, I've got some of that magic tape handy all the time. Actually, reading those messages is kind of making me feel a bit itchy. But, when
oh, my God, Christina.
No, it's just when you read about itching, you start feeling a bit itchy, don't you?
Well,
I do.
What is that? Yeah, that's like a human thing when someone starts, when they, talk about, Okay, so we're doing, it seems pretty unanimous other than, what was there? There was one, a spicy food person?
Yeah,
Spicy.
I think I would be very surprised if it was something else, but I wouldn't be completely surprised, Daniel, because it seemed very easy.
No, and I like the way, it's always great with like all the emails because I think sort of all the pertinent things were brought together here. So it's confirmed with Pinworm, right? It was actually one of those paddles. They have these sticky paddles, right? And apparently a bunch were ordered quite a while ago and they're tracked down and it's done. And you basically have to give it to the person. You have to say, all right, here's the deal. First thing in the morning, you're going to wake up, you're going to go and you're going to put this right on the anal area there, and you're going to put it back into the little thing, and you're going to bring it in where you look under the microscope, and you're going to see the pinworm eggs, right? But we have this whole issue because there's several features going on here. So one is this issue with reinfection, right? So you got to treat mom, you got to treat the husband, and the 2-year-old is probably the source. But then the 2-year-old, even if you treat the 2-year-old, they're going to get re-exposed because it's probably in the child care environment, right? The daycare center.
Yep.
So this becomes an issue. So reinfection, that's part of the issue. You got to treat mom, you got to treat the child, you got to treat the husband. But then as some of our people wrote in, there's this interesting life cycle issue. And we love that in parasitology. So, you get treated, everyone gets treated, you've killed, we'll say the adults, but now you've got eggs and the eggs are all over the place because when the female comes to that anal area, the eggs are not just released, the uterus is inverted and the eggs are sprayed like several feet into the air. So the eggs are everywhere, they're all over the place. And these eggs are viable for 3 weeks in the environment. And, people go crazy. They wash everything. They do it in hot water. But you got to get the eggs off of everywhere because you reinfect with an egg. And let's say you get treated 2 weeks later. You still can get reinfected for the next week from even like what was there before you even started. And so this is what some people bring up is sometimes we have to have this cadence where you treat, 2 weeks later you treat, 2 weeks later you treat. And sometimes you may have to even do that again just to sort of break this cycle. But then you may end up in a particular person like this individual who gets very symptomatic. They may need to periodically be on some kind of a treatment. So each time they do get reinfected from the child who gets reinfected, you do something. But then I thought one of our emailers brought up one of the interesting phenomenon that we'll see after a while. After you've gone, and this woman has actually had symptoms for long enough, you actually can start to develop an irritant dermatitis of the anal area. The way someone might after like a particular diarrhea get this sort of post-infectious irritant bowel or irritable bowel. So you can actually end up with, even though you've treated it. So then you've got to do sort of a little more. And usually in cases like this, I'll recommend they make these like preparation anal wipes. And so in addition to treating repeatedly, actually just some good anal care to get that inflammation in the anus to go down. And then there's the psychological distress, right? And the embarrassment of having this, over and over again. So
I just want to say that this worm is almost the epitome of evolution when you think about it, right? So first of all, the mom hangs out in the least hospitable place in the human body, right? In the rectum, the large intestine of all things. And then like a little hobbit comes out at night, pokes her head through the anus and then sprays these eggs everywhere. And then, of course, they make you itch. You pick them up under your fingernails, and then everybody puts their fingers in the mouth at one point, especially kids, right?
Oh, yeah.
And then the kids want to put their hands in your mouth. That bit with the teeth, that really rung true. So this exploits human behavior perfectly.
Yeah.
Right?
Oh, yeah.
And also, I mean, if this happened when we were hunter-gatherers, I don't think it would happen because we don't have any bed sheets or anything like that to contaminate, right? But this is a function of modern human society. Totally. It's just amazing. So in this case, what was done to cure her? Yeah.
So it was basically, as everyone said, you got to retreat mom and the 2-year-old and the husband. And you got to everyone's got to say, all right, we're going to sign up now. 2 weeks, 2 weeks, 2 weeks. You got to do several cycles. It's better to slightly overtreat. And as someone pointed out from Harrison's, the parental palmoate, for some reason I always want to put an L in that palmoate, but it's just palmoate, not palmoate. That's inexpensive. It's kind of like a minty chalk flavor. So you do that and you just got to get everyone on board. You don't have to test the husband. You don't have to test the child because everyone's got it. Don't worry. If mom's got it, 2-year-old's got it, the husband's got it. And so you just have to get everyone on board. And we do recommend all the washing everything, the bathing in the morning, and then, using something to help with that anal irritation, which can even persist for a little while. I mean, it's been going on a long time. It's going to take a little while for that to calm down. It's really an anointing treatment, isn't it? Yeah, it's not so bad. I mean, not the drugs, but having to treat everyone, the timing, and then you got to clean your house, and then you got to tell daycare. Well, but yeah, that's the thing I wonder. Do you really have to tell daycare? I mean, 10% of kids under the age of 14 probably have pinworm. I mean, this is ubiquitous. So I'm not sure you need to embarrass yourself and go to the daycare. It's a little bit like head lice, right? Yeah, yeah. A lot of kids in daycare have it, and and then you have to take your house apart to clean it.
Not so much with the head lice, I guess, but yeah.
Yeah, you do. Yeah. You gotta put everything in a dryer to kill them. You gotta all this stuff. I mean, I know I've been through that. I've never been through the pinworm business, but the head lice I have. And then you're like excommunicated because of this. There's a list.
Yeah, we definitely had the pinworms in the house.
Oh yeah,
on more than one occasion. I mean, I do have 4 kids, so happens quickly. Lots of sheets to wash.
Yeah. Okay, let's give away a book. We had 11 guessers, 12 with Helen. Let's go a random number between 1 and 12, and let's see what that is. That's number 7. Who is number 7? Shlomi. First time guesser, huh? Okay, Shlomi, so this is your chance to tell us where your ID fellowship is going to be, because that's what Daniel wanted to know.
Yeah, anyway, that's great.
Shlomi, you are the winner. So what you need to do is very simple. You just send an email to TWiP@microbe.tv, which you've already done at least once. And in that email, send us your address, your mailing address. Some people send us their email address. No, we already have that, and it's not useful for sending a book. Send us your physical address, and then if you're outside of the U.S., include your phone number. And in the subject line, please say TWiP 286 book winner. That way we'll see it right away. Okay, Shlomi, congratulations. Hope you enjoy the book. Okay. We have a hero left over from last time, where we didn't have time, Christina, right?
Yeah, we do indeed. So before I introduce that hero, actually, I just want to maybe just briefly say something about how we do celebrate scientists. So, for example, when a parasite is named after somebody, or when a monument is built to honor somebody else, or also when we tell a story of discovery, I think we are always making a choice about who gets to be remembered. And I think this is quite important in our context, because quite a few of our heroes, or the heroes that I've talked about, actually come from an era that is maybe, where equality is maybe not as popular or wasn't as popular as it is now, at least in some parts of the world. And so this choice really that we make, particularly in 19th century colonial science, that was never really made in favor of the people who actually bore the heaviest burden of the diseases that were being studied, or whose knowledge was quietly added to the scientific knowledge without credit. So I just want to remember that while it's okay to appreciate the heroes that and the science that they did that led to more understanding, I would also like us to acknowledge the context in which that science happened. I've been wanting to say that for a long time, but I always forget, but I've taken a note. So yeah. And with that in mind, I'm going to tell you today about our hero, who is Otto Edward Henry Wucherer. And I'm sure you can guess one of his achievements by just learning the name. And his story maybe is a little bit underappreciated in the history of parasitology. So Otto Edward Henry Wucherer was born in July 1820 in Portugal, and he had a Dutch mother and a German father. I think I'm probably going to call him Otto or Wucherer because that's a bit easier. I don't really have any information about his early life, but I learned that as a young child he spent a year or so in Salvador, which is the capital city of the Brazilian state Bahia, I think, where his father was manager of a commercial business and will return to Bahia later. So the family then lived in Hamburg, where Otto went to school until he was 15. And actually, after the death of his father, he'd worked in a pharmacy, and he kind of earned the resources to fund his own university studies. So he didn't have a wealthy family background, but he went on to study medicine at Tübingen in Germany, and he graduated with a doctorate in 1841. And from there, he went to practice first in London, then in Lisbon. And I assume that having spent his early childhood in Portugal and Brazil, he was probably fluent in Portuguese. So, and at the age of 23, he moved to Brazil, where he settled eventually in Salvador, which at that time was still a main port for the then still legal slave trade. And the Atlantic slave trade was diverting into history, I guess, was banned in Brazil in 1850, but domestic enslavement continued until slavery was abolished in Brazil in 1888. And I think that was probably the final country in the Western world to end slavery. So I just wanted to mention that as well. But I am a parasitologist, so hopefully if I made some mistakes there, you can forgive me. So what I'm trying to say is that when Wucherer arrived to set up practice in Salvador, he was working in a city where slavery was not a historical footnote, but actually a reality, and where the disease study fell most heavily on enslaved and formerly enslaved people. So he practiced medicine, but he was also a keen scientist. He had lots of questions, and together with two colleagues, the Scottish doctor John Ligerwood and Patterson, and the Brazilian doctor José Francisco da Silva Lima, he co-founded the Bahia School of Tropical Medicine. And this was quite an unusual institution for the time, because the founding doctors and scientists were not satisfied with relying on European knowledge, but wanted to engage with diseases that were affected people in Brazil. And they eventually became part of a group of nearly 30, mostly Brazilian doctors, which became known as the Tropicalistas. And essentially, they revolutionized tropical medicine in Brazil. And I think that's noteworthy. They also founded a medical journal in Portuguese, which was used to disseminate their findings. And this institution, they really made discoveries in parasitology and contributed to our understanding, for example, of beriberi, which is not a parasitic infection, but vitamin B1 deficiency. Is that right, Daniel?
I'm gonna defer to you.
I think so. Anyway, leprosy and tuberculosis, and also other tropical diseases, so infectious and not infectious. Probably every doctor of these founding doctors would probably deserve to be a hero. But I'm just going to focus on Otto now. So in 1865, Wucherer actually identified hookworm, Ankylostora duodenale, in the intestines of patients at autopsy. And he did recognize this as a cause of the anemia that we've talked about many times, that really was an enormous burden of suffering and death, particularly in the enslaved people and agricultural working. And I suppose that sounds familiar because this was one of the achievements mentioned in a recent hero segment when I talk about Bailey Ashford in Puerto Rico. And I think at this point it's probably worthwhile rectifying the timeline of these almost identical discovery, because Ashford is quite late in his own. Ankylostoma duodenale was actually first described in 1833 by an Italian doctor, Angelo Dubini, and he described the worm but did not make the link to anemia. And Wucherer identified hookworm, I'm not sure which one actually, in Brazil in 1865, and more importantly, he connected it to the anemia seen in the patient. So, and the hookworm reports began to increase in the world during that time, but Wucherer's was really among the earliest published connections, and actually that predated the European recognition of the link, and also Ashford's in Puerto Rico. And I'm not sure actually how much of this earlier discovery Ashford knew, but maybe none at all, because there was no Google, and there was no internet, and communication just a bit slower. And also the other thing is Wucherer actually published in Portuguese, but most American and British medical training was informed from English, French, and German literature. So it may have just been sitting there. So that's that. And so really we should maybe actually attribute this discovery to Wucherer and Ashford, maybe just in a different context. So in different parts of the world we have different worm discoverers, but that obviously wasn't even his only discovery, as you might have guessed from the name, because in 1866 came then the discovery for which he is most remembered, although not during his lifetime. So he did actually examine a woman with chyluria, which is a milky white urine, and he found microscopic thread-like organisms in the urine that he correctly identified as the larval stage of a filarial worm. And he did publish his findings in this Brazilian medical journal, which, as we have already discovered, was not widely read globally because it was primarily distributed within Brazil. But this appears to be the first description of what we now know as microfilaria of Wuchereria bancrofti, the parasite responsible for lymphatic filariasis. What is worthwhile noting, though, is that the European mainstream medical community did not take notice. So when Joseph Bancroft in Brisbane isolated the adult worm a decade later and sent specimens to London, it was Bancroft's name that was attached to the parasite by the British scientific establishment, initially without knowledge of Wucherer's earlier discovery. I do actually have draft notes for Bancroft, but maybe that would be another day. So Wuchereria bancrofti was originally named Filaria bancrofti in 1877, named after Bancroft. And it was only in 1921 that the genus Wuchereria was created and the parasite became Wuchereria bancrofti, honouring both men, and about 44 years after Wucherer's description of the microfilaria. So he left Bahia in 1879. He went back to Lisbon. He was not a well man. He died quite soon after, possibly as a result of stroke when he was only 53, and essentially long before his name was included in the name of the parasite that he described, and before transmission was worked out, and also before hookworm was recognized as the cause of much morbidity. So I'm not sure what drew Wucherer to Brazil when he could have chosen to build a comfortable European career. But I think what he achieved was quite remarkable, even if this was only recognized much later. And this school that he founded, the Escola Tropicalista, was in a way an early act of decolonization, or maybe it's just my hindsight really that stinks though, because of course he was still a European immigrant, and the patients he worked with had no power over how they were examined or how the knowledge gained was used. For example, we have no recognition of the woman with chyluria whose urine contained the microfilaria. She goes completely unmentioned. But we can acknowledge them, and hopefully I have done that. So I think he does deserve, Otto Wucherer deserves to be celebrated as a hero, both for his discoveries, but also for co-founding an important medical institution in the 19th century that was not based in Europe or in a similar place. So that was quite a long hero, but I think I had a lot to say. So I enjoyed that.
I think you make good points about how, it's one of the things that I find fascinating in infectious disease, just how intertwined it is with history and society and parasitology, right? With all the colonization and sort of things for the benefit of the military and Europe and other parts of the world. And I think we do sometimes sing the heroes of Western Europe as opposed to really talking about a lot of the people themselves that really suffered.
All right. Thank you, Christina. Now, Daniel, do you have any other cases for us?
I do. And this is an interesting case. I think it's an interesting case. I think you guys will as well. So this is a recent case. And it's a woman in her 20s. She lives in New York City, and she goes into one of our urgent cares in the city with 3 weeks of pretty significant diarrhea, and it's not getting better. So a couple things about this young lady. She's otherwise healthy. She hasn't had any problems. She doesn't describe any travel, basically lives in New York City. She works in an office there. It is interesting that is talking to the provider, since they're aware of some things that might be going on, they do take a little bit more of a detailed history. Turns out at some point prior to the onset of the diarrhea, this individual does report eating at a Taco Bell. We don't know if that's relevant. I was entertained when that was added to the history. So presumptively, this individual is put on a twice a day medication, and a molecular test of the stool is sent off, which actually confirms the diagnosis.
That's timely, Daniel.
All right. I think that if anyone's paying attention, maybe they'll be able to figure this one out. But any questions?
A lot of people will have paid attention because that episode potentially was
the episode. What are you talking about, Christina?
We don't know what you're talking about.
I don't know. Sorry, I know it's late here. It is late.
How long before the diagnosis did she eat at a Taco Bell?
See, that's a good question because mine was like I was entertained that was asked. I don't know if there's a connection, right? But my question to the urgent care was: so they had a Taco Bell. Was that like just a few days before they got sick, or was that more than a week before they got sick?
She doesn't know. They don't know.
They don't remember.
Okay. And the other question is, what did she eat at Taco Bell?
That's a good question. And we didn't, the detail wasn't there, but I know what I wanted to know about.
Yeah, I do too. And because, you can get all kinds of things at a Taco Bell.
Yeah. And I wanted to know not only what did she get, but what did she have on that particular item?
Exactly right. Exactly.
Maybe also what kind of other dietary habits she had, because presumably you can't eat in Taco Bell every day. So maybe it'd be quite interesting to know.
I think you can.
What she ate. You can.
I think you can. No,
I don't think I could. But did she have? What was her diet like?
Yeah, is this a vegetarian? Is this someone who tries to eat healthy, or is this just someone who's like, get all the vegetables out of my way? I just want the meat.
Now, let me ask you something, because recently we had a case with voluminous ostomy output, if you remember.
Oh, yeah.
Is she immunosuppressed in any way?
No, it's a completely healthy individual. I think that's significant. And 3 weeks, the diarrhea is just still going. It's not getting better.
Any fever?
No fever.
So her only complaints is the diarrhea.
And it won't go away. It's been 3 weeks. She finally said, I need to see someone because this
how is she managing the diarrhea? Because, you can get dehydrated, right?
Yeah. No, so she's trying to keep up with the losses. She's taken some over-the-counter medicine, but...
And how would you describe her diarrhea?
It's quite a lot and watery.
Quite a lot and watery. No blood?
No described blood, no.
Mucus?
Not described, no.
Smell?
No, she doesn't sort of raise any issues with smell.
Okay, so essentially just runny poo.
Yeah,
runny poo.
Runny poo.
Okay.
What is that? A Scottish medical term?
I think it's you do it with the peas. You get some runny poo. Yeah,
I think locally here you might say a runny jobby.
Runny jobby, really?
Yeah.
Gosh.
Yes. Yeah. So some kids here call poos jobbies.
Okay.
Well, I think we've asked enough questions, right? Christina, we got some good ones in there.
Yep.
So, folks, you got a couple of weeks to guess this one. You send your email to TWiP at microbe.tv and put case 286 guess in the subject line. That way we know what you are writing about. So that is TWiP 286. You can find the show notes at microbe.tv/TWiP. You can send your guesses to TWiP at microbe.tv. And if you enjoy our work on science communication, teaching you science education for free, we'd love your support. Go to microbe.tv/contribute. Daniel Griffin is at Columbia University Irving Medical Center, parasiteswithoutborders.com. Thank you, Daniel.
Oh, thank you. And everyone, be safe.
Christina Naula is at Glasgow University. Thank you, Christina.
Oh, thank you. I had a really fabulous time, as usual.
I'm Vincent Racaniello. You can find me at microbe.tv. I'd like to thank the American Society for Microbiology for their support of TWiP and Ronald Jenkins for the music. You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon.
Another TWiP is parasitic.